So, thank you organizers for giving me opportunity. We are discussing I think, very neglected topic, but very interesting that it's not a benign condition. So, I want to highlight that point. MINOCA, how to approach and how to manage. So, well, we were dividing ISD into stable and ACS. And in stable or ACS, when it is not obstructive CAD, then in ischemic heart disease, stable CAD, we call it INOCA, and in ACS we call it MINOCA, where the MI with the non-obstructive coronary arteries, and ischemic heart disease with non-obstructive coronary artery disease in a stable ACS. So this is changing philosophy, where non-obstructive disease is not a false positive thing. It's not a benign thing. It has many etiology and importance in long term. So what we see in the coronary circulation, we see in the epicardial segment only 5% of the coronary circulation, and remaining 95% is there in the microvascular. And what you see is non-obstructive coronary artery disease in post-MI. It's up to 1 to 13% patients we can have this condition, and what you don't see is the microvascular dysfunction, where the microvascular vasculature is at fault and endothelial dysfunction may be there. So diagnostic criteria for MI with non-obstructive coronary artery disease. So this is recent 2019 AHA statement. And they are concentrating MINOCA only on the ischemic causes. There are many non-ischemic causes also being to be ruled out before describing it as a MINOCA. So for diagnostic criteria, the acute MI criteria should be there, number one. So positive cardio biomarkers should be there. Then clinical evidence of infarction should be there. And symptoms of ischemia, new ischemic ECG shifts, or imaging evidence of new loss of viable myocardium or new regional wall motion abnormality in echo. Second thing should be there, that is non-obstructive coronary artery on angiography, normal, less than 30% or 30 to 50%. So less than 50% obstruction. No specific alternate diagnosis for the clinical presentation. So we have to rule out other things. So these three things, if they are there, then we call it MINOCA. And the prevalence wise, this is large cohort of 176,000 patients, and it showed 6%. This is average. It may be 1 to 13% incident prevalence. These are the potential mechanism for ischemic causes in MINOCA. So it's a clinical syndrome. It's not a final diagnosis. Just like heart failure, it's a clinical syndrome. It may be due to plaque disruption. It may be vasospasm. It may be dissection. It may be thromboembolism. It may be microvascular dysfunction, or it may be supply-demand mismatch, that is type 2 universal definition of MI. So MINOCA should be considered as a working diagnosis. It's analogous to heart failure and thus prompts further evaluation regarding its underlying mechanism. So what should be the next? So etiology-wise, as we have discussed, that it may be coronary causes. The coronary causes highlights the vasospastic angina, metal angina. Coronary microvascular disorder like coronary slow flow, or microvascular angina, or microvascular spasms, or coronary plaque disruption, spontaneous coronary thrombosis or embolism, missed obstructive CAD. So you have to review the angiogram to rule out this missed obstructive CAD. Then non-coronary causes may be myocarditis, Takotsubo, DCM, SCM, pulmonary embolism, renal impairment, stroke or sepsis. These should be ruled out. So these are not counted as MINOCA. This statement of AHS is that ischemic causes should be included in the MINOCA. So this is one example, the case study of 55-year-old woman. It is she had enterostomy at presentation. Troponin T was raised. ECG changes were there. So it's an acute MI situation. And then angiogram shows that no significant coronary stenosis, non-obstructive coronary arteries. D-dimer was negative and LV angiogram was normal, so no apparent cause for presentation, other causes. So MINOCA is the diagnosis. It's a working diagnosis, and myocardial infarction with the non-obstructive coronary artery disease. So what we should do in such cases where we found that there is no obstruction but acute MI situation is there. So typically there is a rise and or fall of cardiac troponin with one level more than 99 percentile. Plus ischemic sign or symptoms, plus non-obstructive coronary artery disease less than 50%. So if it is clinically overt diagnosis, we should think of alternative diagnosis like sepsis, pulmonary embolism, cardiac contusion, or other non-cardiac rise of troponin. So they should be ruled out by doing additional investigation like D-dimer and others. And then clinical presentation, if it is, so we coming towards the working diagnosis. So we first should exclude the missed obstruction. We should review our angiogram if there is a small vessel obstructed, which we have ignored in the initial phase, epicardial coronaries, or if there is some myocardial injury in non-ischemic mechanism. So we should review the angiography, we should do the LV function assessment, and we should do the contrast MR. It's very helpful in MINOCA situation to document the myocarditis or Takotsubo, or we can find in the review angiography the obstructive CAD or coronary embolus or spontaneous coronary artery dissection. We can do to rule out this significance, we can do the FFR also for this, or we can do the IVS or OCT. So finally, after this working diagnosis, we come to the conclusion that it's a MINOCA, where myocardial infarction is there, and we ruled out the other non-ischemic causes, and non-obstructive coronaries are there. So we can finally to find out the actual cause behind this MINOCA. So this is working diagnosis like heart failure, and then we are finding the cause of heart failure. So we are finding the cause of MINOCA. So we can do the contrast MR to come to that we may have missed the infarct, so it can be picked up, small infarcts, or coronary vascular imaging can show the plaque disruption, coronary embolus or dissection, or coronary functional assessment can be done to document the coronary artery spasm or microvascular disease, and ultimately we can conclude to unclassified MINOCA if no reasons are there. This is the ESC recommended diagnostic and therapeutic algorithm for management of MINOCA. So universal AMI criteria, no angiographic stenosis, no overt causes at presentation. We ruled out the non-ischemic causes. Then invasive investigation, review the subtle or missed angiography finding, and we can give the intracoronary nitrate to rule out the coronary spasm. We can consider the LV angiogram or echo for Takotsubo or other cardiomyopathy. We can do the IVS OCT. We can do the pressure Doppler wire for microvascular dysfunction. We can do the provocative testing also for coronary spasm. So it should not be used in probably in the acute phase of MI. And laboratory assays we can do for the type 2 MI where the supply mismatch is there, demand supply, or we can do the D-dimer to rule out pulmonary embolism, thrombophilia screen, or BNP. Then MINOCA etiological diagnosis is confirmed. It may be type 2 MI or plaque disruption or dissection, Takotsubo or epicardial spasm or coronary thromboembolism. These may be the causes. And if diagnosis is not confirmed, we can go for the cardiac MRI. It's very helpful, where the late ganglion enhancement may document the myocarditis, or we can see the missed acute MI small infarcts, or we can do the TE for ruling out the cardioembolism causes. So CMR imaging is a key investigation in identifying the underlying cause. And this is one example where the angiography portraying subtle lesion in the mid-LAD, but in MRI we can see the mid to distal anteroseptal valve LGE, and still frames from both axes showing the mid to distal LAD infarct. So this infarct can be, smaller infarcts can be documented, which has been missed in the echo. So cardiac MRI findings, we can find out the myocarditis, Takotsubo, dilated cardiomyopathy, SCM, others. So these can be documented in cardiac MRI in MINOCA cases. So recently, Monton et al. Demonstrated that the provocative test, acetylcholine or argonabine, is safe in patients with MINOCA when other causes of myocarditis, Takotsubo, and coronary thromboembolism has been excluded. And 20 years ago, it was already showed that hyperventilation could be used for provoking the spasm, and with sensitivity and specificity of 62% and 100% respectively. And another modality is there, OCT, where largest series of vasospastic angina documented in 69 patients and 80 spasm locations in the OCT has been documented. And OCT registered thrombus as a 28% and plaque erosion in 26% and 61% has irregularity of lumen. Only one patient was having thrombus or plaque, and intimal thickening could also be the risk factor that contributing the vasospastic angina. So OCT can also be helpful. And in management of MINOCA, the fundamental consideration is identifying the underlying cause of this heterogeneous syndrome, because that will determine the appropriate therapy. So we can choose the statins as a potential therapy in plaque erosion or rupture when we can document it by the OCT or IVS. We can use for antiplatelet or anticoagulation if the thrombosis or embolism is documented in OCT or other test. And calcium channel blockers can be helpful if it is a coronary artery spasm or microvascular dysfunction. So, treatment of subject with this proposed medical treatment for MINOCA is there. So, in abnormal endothelial function is documented, then we can go for the ACE inhibitor, statins, L-arginine, aerobic exercise, or EECP. If abnormal non-endothelial function is there, beta blocker or nitrates are helpful. Anti-anginals can be used as a renolazine, ibabridine or xanthine derivatives. Abnormal smooth muscle function is fringe metal is there, calcium channel blocker, and of course nitrates are helpful. And abnormal cardiac nociception, we can think of TCA, tricyclic antidepressant, or spinal cord stimulation or cognitive behavior therapy. So no randomized clinical trial on secondary prevention is there in MINOCA, and no large observational study evaluating different treatment. So no evidence-based guidelines for treatment. Medical therapy for secondary prevention, so statin, ACE inhibitor and beta blocker and DAPT, they have been seen in the large study registry, SWED Heart Registry, and they found that statins and ARB are very helpful in reducing the MACE, and total 9,000 patients they studied, and they found the outcome of MACE was and survival curves are separating for statin and ACE inhibitors, and DAPT is not showing any benefit or loss. And subgroup analysis for there is no sex difference except in ACE-ARB cases. So in concluding this SWED Heart Registry, they found that long-term clinical benefit of treatment with statin and ACE-ARB on outcomes, and trend toward positive treatment effect with beta blocker and neutral effect of DAPT. And it's not a benign condition. So friends, MINOCA has a 1.1 in hospital mortality and 12 months 3.5% in mortality. So it's a huge burden, and although outcome of MINOCA is strongly dependent on the underlying cause, its overall prognosis is serious with 1 year mortality of around 3.5%. Hence, patients with MINOCA should receive the same clinical attention as acute MI patients who have single or double vessel disease, and not merely dismissed as having insignificant clinical conditions. And I'll skip this slide. To conclude, MINOCA should be considered as a working diagnosis. It requires routine evaluation for treating underlying causes, and cardiac MR imaging is a key investigation in identifying this underlying cause. And be careful in treating patients with MINOCA. Overall prognosis is serious with 1 year mortality of 3.5%. Algorithm in treating MINOCA is suggested by ESC guideline, and during the diagnosis of MINOCA, one should always have in mind that possibility of vasomotor abnormality of coronary artery disease may be there. So they can be provoked by acetylcholine ergonomine, but also the hyperventilation can be helpful if these medications are not there. Intracoronary imaging allows the detection of underlying causes and allows the application of an adequate algorithm. Thank you very much.
Thanks for the comprehensive review on this MINOCA. I would like to ask one question. If let's say if there was a coronary thrombus in the coronaries with any patient with MINOCA, so what is your take on use of anticoagulants in such patients?
Definitely.
Besides aspirin and all those anticoagulants.
That's why we have to find out the cause, and one of the causes is atherombolism or the thrombus or the plaque disruption, and we have to treat it like that only. We should not ignore it. It's a MI, and it's
No, I'm asking about the long-term use of oral anticoagulant. We should continue with oral anticoagulants or
it's
use
a
of
it's
NOACs?
it should be treated like a ACS, which we are using. We are not using anticoagulation for long term, but it depends on the etiology. What if it if the, it's a atheroembolic situation, and if the source of embolus is, you find out in the TE that there is a thrombus is sitting inside the heart or somewhere it's throwing it out, then you can think of long term anticoagulation.
Any
Okay.
questions from?
I think in MINOCA, before labeling any patient with MINOCA, especially in ACS patient, it is always better to review the angiogram, at least
That's the
by
first
two,
step.
by two different operators. And if there is a subtle doubt of plaque eruption or erosion, then it is always better to do the imaging if they are available
On
in
table,
the
on
cath
table.
lab on table. Because these patients, if you only left these patients on medical management, then they are more prone to reinfarcts in future.
Okay, that's, I think, the time done for the session. I'd like to thank Professor Jain and the chairpersons and members.